Okay, 42 liters. I want you to take just a second to let that massive number really sink in. If you weigh somewhere around 70 kilograms, you are walking around with 42 liters of water hidden inside you right this second. It's a staggering amount of fluid. And keeping it perfectly, meticulously balanced, well, that is honestly one of the most incredible, high-stakes acts of physics and chemistry happening anywhere in nature.
So, welcome to this explainer. Today, we are unpacking the completely inextricable relationship between salt and water in human physiology. We're going to see exactly how your body manages this crazy delicate balance, what happens when it all goes completely wrong, and how clinicians actually use medical physics to pull you back from the brink.
Here is our roadmap for today. We'll start off with our internal fluid compartments, then look at the master hormonal controllers. From there, we'll tackle volume and tonicity disorders, zoom in on SIADH and diabetes insipidus, and finally, look at restoring the balance.
Let's jump right into part 1, our internal fluid compartments.
It's wild to think about, but 60% of our total body weight is just water. We tend to think of ourselves as solid beings, right? Made of muscle and bone and tissue, but the absolute majority of your physical mass is fluid. You are, quite literally, a highly structured walking bag of water.
So, where is it all? Out of those 42 liters, a massive 24 liters are trapped entirely inside your cells. That's your intracellular fluid. The remaining 18 liters make up the extracellular fluid. But check out how this breaks down. 13 liters are interstitial, basically just floating around in the microscopic spaces between your cells. That leaves only 5 tiny liters inside your blood vessels. That intravascular blood volume is stunningly small when you consider the monumental work it does to keep you alive every single day.
Which brings us to this number, 4,200, specifically 4,200 millimoles. This is the total body sodium content of that same 70-kilogram adult. Now here is the absolutely crucial point. Water distribution depends completely on sodium. It's the most abundant extracellular cation. And the cardinal rule of human physiology? Water always follows salt. For sure. Wherever sodium goes, water is pulled right along with it by sheer osmotic force.
Moving on to Section 2. The master hormonal controllers.
285 to 295. That right there is the incredibly narrow window of normal plasma osmolality. Basically, osmolality is just the concentration of solutes in your blood. And if that number drops or spikes even a tiny fraction, osmoreceptors in your brain's hypothalamus detect it instantly. They act as these high-alert alarm bells for your body's vital fluid balance.
When those alarms go off, you have 2 vital systems that respond. On one side, we have antidiuretic hormone, or ADH. Think of ADH as the body's ultimate water saver. It's released by the pituitary gland to tell your kidneys to hold on to water, diluting your blood. On the exact opposite side, we have the renin-angiotensin-aldosterone system, or RAS. This is your sodium saver, expertly designed to maintain your blood volume and your blood pressure.
Let's look at this elegant, domino-like cascade of the RAS system. When renal blood flow drops, your kidneys release renin. Renin then converts a liver protein into angiotensin 1, which rapidly becomes angiotensin 2. Now angiotensin 2 is a super potent vasoconstrictor. It clamps down on your blood vessels to keep your pressure up. Finally, it triggers the release of aldosterone, which forces the kidneys to reabsorb sodium. And remember our rule? Water follows the sodium, expanding your overall blood volume.
It really is a beautifully orchestrated symphony of hormones. But it begs the question, what happens when this delicate internal balance fails? Because let's face it, in the clinical world, things go wrong all the time.
That brings us to part 3, volume and tonicity disorders.
First up, let's talk volume. Hypovolemia is when you simply lose too much physical fluid. Think severe bleeding, gastrointestinal losses like vomiting, or even extreme sweating. You just become depleted. On the flip side, we have hypervolemia, which is an excess of blood volume. Interestingly, this rarely happens just from drinking too much water. It usually occurs when the body fails to excrete sodium properly because of major conditions like renal failure or heart failure.
But things get truly dangerous when we shift to tonicity, the actual concentration of sodium. Hyponatremia means your plasma sodium is dangerously low. Because the blood is dilute, water violently rushes into your cells, causing them to swell up. Hypernatremia is the complete opposite. Sodium is too high. Your blood becomes hypertonic, forcefully pulling water out of your cells and causing them to shrink. And when this happens to your delicate brain cells, the consequences can literally be catastrophic.
Section 4. SIADH and diabetes insipidus.
Here is a super stark contrast between two major ADH disorders. SIADH stands for the Syndrome of Inappropriate ADH Secretion. In this state, your body pumps out way too much water-saving hormone, often because of a brain injury or a tumor. You retain massive amounts of water, heavily diluting your sodium, which leads straight to hyponatremia and slow, dangerous brain swelling. On the complete opposite extreme, we have diabetes insipidus. Here, you either lack ADH entirely or your kidneys just ignore it. The result? You rapidly lose massive amounts of very dilute urine. I'm talking sometimes liters upon liters a day, causing extreme thirst and severe dehydration.
So, to figure out which type of diabetes insipidus a patient has, doctors play detective using a water deprivation test. They logically deprive the patient of water. Now, a normal person's urine will naturally concentrate, but in diabetes insipidus, the urine stays completely dilute. So, the doctor gives them a shot of synthetic ADH. If the urine suddenly concentrates, boom, the problem was in the brain failing to make ADH, that's central DI. But if the urine remains uncontrollably dilute, the kidneys are at fault. That's nephrogenic DI. It's just pure, brilliant physiologic logic.
And hey, we absolutely cannot forget the sodium-saving side of the equation. Conn's syndrome, or primary hyperaldosteronism, happens when an adrenal tumor goes completely rogue and pumps out unstoppable amounts of aldosterone. The kidneys are forced to absorb maximum sodium while uncontrollably excreting potassium. This massively expanded fluid volume drives blood pressure right through the roof. But the amazing thing here? It's a very treatable cause of hypertension. You remove the tumor and you completely fix the plumbing.
Finally, Part 5, Restoring the Balance.
When a patient's internal scales are totally broken, clinicians step in with some heavy-duty medical physics. They do this using a highly specific IV fluid toolbox. IV fluids are not just water. Normal saline contains exactly 154 millimoles per liter of sodium, scientifically designed to perfectly match your extracellular fluid. If a patient is hypertonic and needs more water than salt, they might use half normal saline, which has only 77 millimoles. Or they might use complex mixtures like Hartmann's solution, which meticulously throws potassium, calcium, and bicarbonate into the mix. The clinician literally has to match the exact mathematical fluid deficit of the patient to the bag hanging on the IV pole.
But listen, here is the absolute most critical medical rule you could possibly take away from this explainer. Hypertonicity must always be corrected slowly. If a patient's brain cells have shrunk because of highly concentrated sodium, you cannot just flood their system with pure water. If you drop the sodium concentration too fast, water violently rushes back into those brain cells, causing cerebral edema. That is lethal brain swelling. The math has to be precise, and the pacing has to be absolutely perfect.
Which leaves us with this final thought. Right now, as you listen to this, your hypothalamus is reading your blood osmolality. Your kidneys are actively filtering sodium. A tiny chemical shift dictates whether your delicate brain cells swell or shrink. So, considering the incredible, invisible, high-wire act happening inside you every single second, how well are you balancing your own scales today? Keep that in mind next time you reach for a glass of water. Thanks so much for joining me on this explainer, and keep learning.